Hi, I'm Heather, and thanks for watching my presentation of Tripping on the Couch, where I'll be taking you through my systematic literature review of psychedelic-assisted psychotherapy in clinical trials. So, psychedelics include both naturally occurring and synthesized drugs that can alter consciousness and produce intense subjective effects, such as hallucinations and ego dissolution. And the word psychedelic means mind revealing, and many people report their psychedelic experiences as being very mystical or spiritual. And although they've been used for millennia as plant medicines, their clinical history is quite a lot shorter. Clinical applications for psychedelics started kicking off in the mid-40s, and early studies showed incredible success in treating mental health patients. It's actually estimated that tens of thousands of patients were treated with psychedelics by psychiatrists and therapists up until 1970, when the US classified psychedelics as Schedule I drugs, which basically means that they were deemed as having a high potential for abuse with no use for medical treatment, despite lots of promising research. This prohibition led to a 25-year absence of all psychedelic research before studies started reappearing in the mid-90s and began what is known as the psychedelic renaissance. Recent trials have investigated treatments using ayahuasca, ketamine, MDMA, psilocybin, and LSD. These drugs have been applied to various diagnoses, including substance dependence, depression, anxiety, and PTSD. Systematic reviews on treatment outcomes show that these treatments produce significant improvements to clinical symptoms across the board, with both immediate and lasting effects and few side effects, if any at all. These small-scale results indicate safety and tolerability, which means that larger trials are needed to demonstrate efficacy. So looking at the global mental health need, we've seen an annual rise in mental health disorders that cause real suffering to people, and current treatment options are usually ineffective medications with quite negative side effects. Now, this is combined with the fact that funding for the development of new medications has drastically decreased, largely due to the high cost of development and very few therapeutic benefits. So it's not really surprising that parts of the medical community are actually welcoming psychedelics into the field. Just so that we can get a sense of what these treatments look like, I've included this photo taken from one of the clinical trials conducted in the US, and most psychedelic therapies share the following characteristics. So standard practice is to have a male and female therapist, as this tends to create a sense of balance and safety. Patients undergo preparatory psychotherapy, which involves some sessions with both therapists who will be with them during the psychedelic session. And in these sessions, therapists can learn about their patient and also develop a therapeutic alliance. So although they're hosted within a clinic, the drug sessions take place in a room that has a real living room aesthetic with a relaxing ambiance. And as you can see from the photo, patients spend most of the session lying down with eye masks and pre-selected music playing, and the drug session typically lasts for about 8 hours. During this time, therapists adopt supportive, non-directive roles to be physically and psychologically present for the patient. And sometime after the drug session, the therapist and patient meet for integration sessions, which give the patient space to recount and make sense of the experience, and may involve some analysis of the content. This structure is known as the PSI model for preparation, support, and integration. Now, you're probably getting the sense that psychedelic-assisted therapy differs quite drastically to most mental health treatments. And these differences, combined with psychedelics' controversial history of prohibition, mean that researchers are really pushing to collectively apply very rigorous research standards and get these treatments through the mainstream channels of approval for medical use. And this means testing them through clinical trials. So there are some important things to know about how clinical trials work in order to understand the challenges that psychedelic therapies are presenting. Firstly, clinical trials sit within the medical model, which means that their philosophy emphasizes physiological processes as being the mechanisms of change in mental health. Clinical trials are typically used to develop medications which aim to reduce diagnostic symptoms. And in these trials, the objective is to isolate an individual variable of change, usually being the drug effect. Now, psychedelic therapies challenge all these tenets. To start, they integrate drugs and psychotherapy into a blended treatment, which confronts the biological approach to psychiatry. They're also not really attempting to return patients to a baseline. Instead, they create a very disruptive but short-term experience that is thought to act as a kind of mental reset. Finally, psychedelics have incredibly suggestive properties, which means that mindset factors like expectations and goals, along with environmental factors such as lighting or music, can heavily influence the subjective experiences that people have. As a result, drug effects may be very difficult or impossible to isolate by standard research methods. And despite these challenges, it's important to test these treatments for safety and therapeutic benefit. And clinical trial is just the best tool that we currently have for the job. But as a psychotherapist, it's concerning that we're learning about this very integrative treatment through a lens that's biased to prioritize biological processes. Our understanding and use of psychedelic therapies must include a psychological perspective to counteract the inherent bias of the medical model. And since the first step to correcting bias is understanding what bias currently exists, I designed a systematic literature review that asked two exploratory questions. Firstly, I wanted to know how clinical trials of psychedelic therapies are incorporating psychotherapy into their methodologies. And secondly, how might different psychotherapy interventions affect clinical outcomes of psychedelic-assisted therapies? So let's look at how I went about this. The first part of my methodology involved setting the eligibility criteria for my study selection. So I limited my review to include clinical trials that were published in peer-reviewed journals between the years 2000 and 2020. They had to involve adult human participants with a psychiatric diagnosis. Treatments had to be a psychedelic drug combined with psychotherapy or a talking intervention. And if there was a comparator, it was an active or inactive placebo. To find my articles, I plugged these search terms into 4 academic databases, which resulted in a total of 3,475 records for me to sift through. I used the criteria to exclude inappropriate studies until I arrived at 16 selected studies, and you can find their citations in the video description. I combed through these 16 articles to extract their data on the general study and drug intervention characteristics. For the psychotherapy intervention, I looked at the use of the PSI model, any approaches or specific applications described, the number of psychotherapy hours per study, and the treatment schedules. I recorded treatment outcomes, and finally, I performed a quality assessment on all the studies to gauge the risk of bias in all of their methodologies. So as you can imagine, I can't go over all the results of the data that I extracted, so I'll largely focus on the psychotherapy intervention characteristics and just explain the highlights. For psychotherapy models, 15 of the 16 studies used the PSI model. 10 studies described taking a specific therapeutic approach, and of these 10, 9 described a specific application of the approach, although 5 of these were unclearly adapted from pre-existing manuals. In terms of drug interventions, most used either psilocybin or MDMA at high doses. And when I looked at the psychotherapy approaches, I found that 6 studies didn't report their approach at all, while 4 were cognitive behavioral, 2 were existential, and 4 used a transpersonal approach. As you can see, there wasn't really any discernible pattern in drug approach combinations, although MDMA and the transpersonal approach were consistently matched. There are 2 takeaways from these results. The first is that there is a high degree of procedural heterogeneity in the study's psychotherapy interventions, with the only real consistency being in the use of the PSI model. And second, there was a substantial missing information on the psychotherapy approaches and applications. Moving on to the intervention schedule, I mapped out the treatment structures for each study to describe the order in which interventions and assessments took place relative to the baseline measurements, and you can see weeks from baseline at the top there. Purple dots represent psychedelic sessions, greens are psychotherapy sessions, and then blacks and yellows are assessment points. And what I'd like you to focus on in this visual is that the schedules look pretty different from one another. And the main takeaway from this is again that there's a great deal of intervention heterogeneity, which makes it very difficult to do any between studies comparisons. I addressed the question of how psychotherapy interventions might influence treatment outcomes by looking at the correlation between the number of therapy hours and the patient improvement. So on the x-axis, you'll see the percent change of primary outcome measure from baseline to primary assessment. This indicates the average symptom improvement for patients at the end of treatment. On the y-axis is the number of psychotherapy hours per drug session. And when I did a Pearson's correlation, it generated a positive relationship between the variables with an R of 0.44, but the relationship was insignificant. What we can take away is that there is a potential relationship between the number of psychotherapy hours and positive treatment outcomes, but more clarifying research is needed. So let's start to zoom out and get a sense of what this all means and what's in store for the future. I want to take a moment to reflect on what my results imply. First, it's no surprise that my findings support the idea that the psychotherapy interventions are important to treatment outcomes. Past research has demonstrated that the drug and psychotherapy effects impact one another. And so although my findings support this notion, they also beg the next question, which is how. But we'll leave that for future researchers to explore. Secondly is the wide variance of psychotherapy intervention characteristics. And honestly, this makes sense because the studies are still in fairly early stages of development, so it's quite normal to see a lack of standardization. But increased procedural consistency would greatly strengthen research. So researchers will want to move forward by making more consistent methodologies. A worrying finding was that many studies were missing information on the psychotherapy interventions. And this means that studies are difficult to replicate and that their quality could be compromised. Based on the philosophical nature of clinical trials, I anticipated there to be a bias on drug effects over psychotherapy effects. Where the issue lies for me is that clinical trials are generally considered as the gold standard for research. And so any bias they hold gets disseminated to the wider community, which impacts everyone because they're referred to for treatment development, policy making, and therapy practice standards. So even if non-clinical research tries to correct the balance by focusing on psychotherapy interventions or maybe using other research epistemologies, it's questionable as to whether their results will be equally regarded next to those of clinical trials. So arguably, it's the responsibility of clinical trials to challenge the status quo of methodology standards in order to better reflect the influence and complexity of the psychotherapist's role in psychedelic therapies. There are important takeaways here for researchers and practitioners. For researchers, my study really points out how the models or systems that we sit within when doing our research will impact the methodologies and the resulting outcomes of whatever we're testing. Future research in this field needs to increase the focus on psychotherapy interventions to reflect the integration of mind and body that psychedelics confront us with. An important message here for practitioners is to remember that research is really central in determining how we treat mental health disorders and conduct our practices. And not just the results of research, but the methods as well. It's therefore fairly critical for us to understand where that research comes from, who's conducting it, and what philosophy of science and knowledge they've used to design it. This is really a reminder to question our sources and ask, what's missing? Finally, a takeaway for everyone, especially those unfamiliar with psychedelic sciences, is that this is an important field to keep an eye on and to question our beliefs about them. For one, MDMA and psilocybin are predicted to achieve FDA approval in the next 5 years or so, so these therapies are gaining legitimacy quite quickly. It's true that these compounds have a controversial history with lots of social stigma, which is challenging to look past. And of course, caution is required with any new medication, and these compounds are technically still illegal. But they're also showing substantial promise and have the potential to help a lot of suffering people. So it's important that we understand our own biases and closely examine the research when looking at this developing field of psychotherapy. I hope you enjoyed this presentation, and I'd love to answer any questions you might have about the subject in the comments below. Thank you so much.